My name is Kate Hinton, and I am presenting on complex regional pain syndrome. Here are some of the general features of the disorder. Complex regional pain syndrome is a rare and chronic nerve disorder that can be divided into two subtypes: CRPS type 1, which was previously known as reflex sympathetic dystrophy, and CRPS type 2, which was previously known as causalgia. While both subtypes most often occur after an injury or trauma, they are discerned by an established nerve injury. Nerve injuries are lacking in type 1 but present in type 2. The etiology is poorly understood. It is considered to include dysregulation of multiple pathways that are not limited to the central nervous system, peripheral nervous system, sympathetic nervous system, and inflammatory paths. Risk factors include female sex, Caucasian ethnicity, fractures or other trauma, immobilization of an extremity after injury or surgery, and pre existing conditions, which can include anxiety, decreased bone mass, and nerve pain. Comorbid conditions can be comprised of depression, headache disorders such as migraines, and substance abuse. CRPS is higher among individuals with upper extremity involvement compared to lower extremity, although lower extremity involvement has higher prevalence in younger athletes who develop CRPS. CRPS type 1 is more prevalent. Signs and symptoms may vary. They can include, but are not limited to, allodynia, vascular changes, atrophic changes of the affected extremity, muscular weakness, localized swelling, and autonomic dysfunction. CRPS can present in two phases: the acute or chronic phase. In the acute phase, the limb is warm and represents the typical inflammatory process. The chronic phase, where the limb is cold, can depict atrophic changes. For the clinical assessment, we will discern between the acute and chronic phase of CRPS. It will begin with pain out of proportion to an exciting event. The acute warm phase has cardinal inflammatory changes such as erythema, edema, pain, heat, and loss of function. The chronic cold phase has degenerative changes that lead to decreased active range of motion, overall weakness, and reduced strength of the extremity, colder skin temperature when compared to the unaffected limb, cyanotic or mottled skin discoloration, and increased sensitivity to touch. Specialty exams can include other pathologies, but there is no single exam that defines CRPS. X-ray, MRI, bone scintigraphy, nerve conduction studies, and Doppler ultrasound can be used to confirm that there are no other underlying causes for the patient's presentation. The diagnosis of CRPS is indicated with Budapest criteria. Budapest criteria requires that the patient has at least 3 of the 4 symptoms and 2 of the 4 signs in the following categories: sensory, vasomotor, pseudomotor/edema, and motor/trophic. The patient must also experience pain that is continuous and disproportionate to their original injury. CRPS cannot be diagnosed if another phenomenon can better explain the signs and symptoms. And again, there is no gold standard for testing or imaging that confirms CRPS. Physical and occupational therapy is a first-line treatment for CRPS. Pharmacological management includes NSAIDs, opioids, topical anesthetics, antidepressants, anticonvulsants, and steroids. Opioids should be routinely monitored to assess for dependence. Neuromodulation is another option for treatment. Neural stimulation and sympathetic nerve injections, however, do not guarantee complete or lasting reduction of symptoms. If a patient fails the previous interventions, surgical removal of sympathetic nerves and even amputation of the limb are options of last resort. The patient should weigh the risk versus the uncertain benefits of all neuromodulation and surgical alternatives. Because the etiology of CRPS has not been well established, There are not completely proven ways to prevent it. Minimal studies have found that the initiation of vitamin C in post surgical cases could be effective in preventing CRPS. The complications associated with this disorder include addiction and substance misuse or abuse. Patients are often overprescribed pain medications, therefore increasing their tolerance and risk for misuse. Chronic pain is also associated with depression and anxiety as patients feel they are isolated and alone in their diagnosis. Since there is no certain standard of care for CRPS or a definitive cure, patients can become exasperated with treatment. Fear of movement due to inappropriate pain of the affected extremity can lead to disability for the patient, thus leading to a worsened course of CRPS. Disability with a diminished quality of life can contribute to psychological and emotional stress, therefore exacerbating one's mental health.